Professor of Pathology at Harvard Medical School and Senior Staff Pathologist at Brigham and Women's Hospital, and we are very proud to have him serve on the MSIC Board of Directors.
Thank you very much, Paul, Mike, Erica, and Tony, for this opportunity. I'm very pleased and proud to present here. I was asked by Mike to put together a very brief presentation regarding COVID, and it's top of mind for all of us. And clearly this has impacted the way that all of us are going about our daily business and going about our businesses. I'm going to briefly talk, hopefully briefly, talk about the virus itself, the disease, our diagnostics that we're working with, what are current treatments, and what about those vaccines, and then what's next. As a disclaimer, I'm very honored and proud to be here before you in presenting this, but these are strictly my informed observations and interpretations. I am not representing either Brigham Women's Hospital or Harvard Medical School, although I am faculty in both places and am a physician and scientist. But these are my observations, and in no way should this be construed as the official word from these two august institutions. So here's the roadmap for what we're going to talk about. This guy on the right is a reasonably good representation of what the virus looks like. We'll talk a little bit more about that. But the roadmap for today is that we'll talk about the virus. We'll talk about the disease that is caused by the virus. We'll talk about treatments such as we have right now. We'll talk about the diagnostics, the PCR test and what that means, and the antibody test and what that means. We'll talk about the vaccine and the rollout on the vaccine, and we'll talk about what's next. And as we go through this, I'm going to very much encourage you to type into the chat comments. And Erica, please interrupt me. It's much more important that I get the questions answered and that people have a clear vision of what's going on rather than me rip through everything. So I encourage my students to raise their hands. You can't really do that, but metaphorically you can go into the chat room. Okay, so that's the roadmap for where we're going. We're going to start with the virus. And coronavirus is actually the one that we're dealing with. It's just one of a large family of viruses. They are RNA viruses. So RNA meaning that the genetic material that they use to reproduce is ribonucleic acid. We are basically DNA based, although we use RNA for doing a lot of the heavy lifting for making proteins and things. But these viruses are just RNA. They have a very small genome, all things considered. They live within a membrane that derives from the host cell that they originally emerged from. And then they're studded on the surface with all of these spike proteins and a couple other proteins. And the spike protein we will come back to over and over again because it's going to be the major protein that is targeted by the immune system, and it's the major protein that's targeted by the vaccines. When we look at this virus, here's a three-dimensional representation of it. When we look at the virus, it looks like it's got a crown, and hence that's where the name corona comes from. And it's that crown of spikes. These coronaviruses, as I already said, are extremely common. And there are a lot of different varieties. They've been around for greater than 10,000 years. So we can find them in Egyptian mummies and other things like that. These are pathogens that have been with us and that we've gotten pretty much used to seeing for long periods of time. Importantly, because of where they come from, when new ones arise, they can infect pretty much the entire kind of range of animals that are out there, bats and cats, birds, humans, dogs, etc. So they can potentially jump from species to species. So they are a little bit promiscuous in that regard. And the vast majority of these guys, the coronaviruses that are around us all the time, cause really mild respiratory symptoms. In fact, most of the time, when you get a common cold during cold season, it's because of a coronavirus that you happen to have contracted. Some of them can also cause GI symptoms, and it's interesting that some of the patients with coronavirus have also had GI symptoms, diarrhea and things like that. So that's the virus. Now let's talk about the virus, the one that we're dealing with specifically. And this has got the long name of SARS-CoV-2. And that SARS-CoV-2 comes from the severe acute respiratory syndrome from coronavirus number 2. Okay, so that's what we formally scientifically call the virus. It's called novel because we've never seen this particular variant ever before, and that's been a major driving force in why it's become a pandemic. So it's novel. It's a new one that's been lurking actually in the animal population out there. We'll talk about that more later, and then has leapt from the animal population into the human population. But we as humans have not really particularly seen this variant ever before. Its virulence, what makes it so nasty is that it's highly communicable. So new strains, and the new strains are even maybe more communicable. It's mostly communicated by aerosols, much more so than contact. But that's one of the ways that it gets around. It is very easily spread. It doesn't take a very high viral burden in a droplet to get into your lungs, and it's very effective at binding and getting started. The other really important virulence about this is that when it gets into its host, it induces a very profound inflammatory response. Now, in general, that's a good thing. That's how we eliminate infectious agents. In the case of SARS-CoV-2, the immune system in some of us, in some of the patients who are infected, is more than just revved up. It is hyper revved up. It causes the pathology more so than the virus itself. An important point about the virus is it's not magical. It is not magical. Okay, so it actually follows, as far as we can tell, all of the rules the viruses for millennia have followed. Fortunately for us, it doesn't mutate very much. There are some other viruses out there in the world, HIV is an example, that mutate on kind of a regular basis. But this one is actually fairly stable. There are new variants that are cropping up, but it's taking a while, and that's good because that allows us to get ahead of them. It means also, because it's a virus and it plays by the normal viral rules, it's amenable to public health measures. We know how it's transmitted. And if we just stay away from each other, we just wear masks, we can mitigate a lot of that. And also because it doesn't mutate much, it means it's amenable to vaccination, meaning that we can go after certain things, these spike proteins, and be able to raise an immune response that will protect us all. And that's the whole point of the vaccination. So that's the virus. Let's talk about the disease that the virus causes. So we've seen these images on nightly news. This is just giving kind of a map. The red dots indicate where we know that there's coronavirus. And this is also a function of reporting. So it looks like vast portions of Russia are completely clear. That's not really the case. So there's not complete reporting. But the larger the dot, the greater the density and the greater the incidence of the disease. And this is COVID-19. So this is the coronavirus disease in 2019. That's where that name comes from. So far, the numbers change daily, as you're well aware. There are over 100 million global cases. There have been 2 million deaths. The mortality, depending on where you are in the world, is somewhere between 1.7% and 3.2%. And again, most of that mortality is because of a hyper-aggressive immune response. Now, there have been other coronavirus diseases that have actually impacted the population of the world. So we're talking about SARS-CoV-2, that's the current pandemic. But there was, you may recall, a SARS-CoV-1 actually that originated in 2003. This one kind of burned out very quickly, and if we have time, I'm happy to discuss why that may have been the case. But there were only 8,000 cases worldwide, but there was a significantly higher mortality. So that was one SARS-CoV-2. There was another coronavirus disease called the Middle Eastern Respiratory Syndrome virus, MERS, originated in Saudi Arabia in 2012, also burned out relatively quickly, but had a very aggressive mortality. And there was a very serious concern early on when SARS-CoV-2 was appearing on the scene that we were going to see something like that. And fortunately, we're tenfold less than that. Now, influenza, just to put all of this in context, influenza is not a coronavirus. It's a different RNA virus. There are 35 million cases annually, so we've already kind of threefold topped that. But remember, this is annually, and an influenza virus comes around every year, and it does mutate somewhat. So But fortunately, it also has a much lower overall mortality in the range of 0.1 to 0.3%. So somewhere between 35% and 0.3% is where we are currently sitting with COVID. Also, to put this in context, so the last great pandemic was the Spanish flu pandemic, which was influenza. So again, not a coronavirus, but to just give you kind of the statistics on that, there were 500 million cases. Now we're getting close to that. We're up to 20% of the total. But at that point, that was a third of the population of the world back in 1918, and it had a 10% mortality. Mortality was higher in that case, mainly because of secondary bacterial infections. Okay, so again, in the United States specifically, the disease of COVID-19, we have 25 million cumulative cases, and sadly, we represent a quarter of the global disease burden. As we heard dramatically over the last couple of days, we're up to 400,000 cumulative deaths. That is a rate of about 1.6%, so that's kind of where we are. And currently, greater than 4,000 or about 4,000 people are dying today. If you put that in context, that's 9/11, that's more than 9/11 happening every day in the United States. And that's what's shown on this curve here, which is just terrifying. A lot of this spiking is a result of things that happened over the Thanksgiving, Christmas, and New Year's holidays. In Massachusetts, we have almost 500,000 cumulative cases, 14,000 cumulative deaths. The death rate is slightly higher. It's because we have a slightly older population in Massachusetts compared to the country at large, and most of the mortality is in the older population. And we're currently at about 70 people dying every day. Okay, so how is it being transmitted, the disease itself? So it's much more aerosol than contact. There's been some concern that contact is there, and there have been various reports about the longevity of the virus on various surfaces. In general, the major feeling is that it's aerosol, hence the efficacy of wearing masks to protect other people, not so much to protect you, but to protect other people. How it works. So how does COVID do its dirty deed? So this is the virus, and the yellow things on the surface represent the spike protein. It interacts with a molecule called the angiotensin converting enzyme receptor, the ACE receptor, so the ACE receptor, on the surface of various cells. And it turns out that the greatest density of these receptors are in cells that are in the lung. So it's an aerosol, it has to bind that way, and the reason that it mainly goes to the lungs is because we have a greater density of the little blue receptors on the cell. It then enters the cell, it is able to get in, and then it reproduces. So this is just a graphic demonstrating the viral replication. It uses the cell's own genetic machinery to make more copies of the virus itself, and then it can cause direct damage. So this is just an image from the National Institutes of Allergy and Infectious Disease showing the pseudocolorized cell that is dying as a result of the virus, which are the little yellow dots, budding off the surface. And basically by taking over the cellular machinery, it causes the cells to die and turn into another viral factory. That's a relatively minor mechanism of disease, however. What's really the problem is here. So this is a normal chest x-ray. Black is beautiful on a chest x-ray. We want to be able to see lots and lots of air. Here's a patient who's got very severe COVID lung disease, and it's all filled up with white. So this fluffy whiteness is in fact fluid, and that's because of the inflammatory response. That's the major mode of disease with COVID-19. This will inform also the way that we think about how to treat COVID-19 in a minute. So it induces a profound inflammatory response that causes leakiness of vessels within the lungs, and actually leakiness of vessels around the body, but the lungs filling up with fluid is where the major mortality is. By causing inflammation, we're also causing clotting, and one of the secondary manifestations of COVID has been abnormal clotting. So people are getting blood clots, pulmonary emboli that go to the lung, or getting clots in multiple smaller vessels within the body, so they can get kidney disease or heart disease secondary to the clotting. So that's really why COVID-19 is such a nasty player, because it induces in a subset of patients a really significant inflammatory response. There are a whole bunch of long haul symptoms, so-called long haul symptoms. We don't exactly know the mechanism for this, and it's also unpredictable who will get this. But this includes brain fog, so patients really don't think clearly or well for long periods of time. They can develop a refractory or persistent shortness of breath. They can develop heart arrhythmias that can in some cases be fatal. They can develop persistent hypertension. And again, we don't understand the mechanisms of these, but it may be secondary manifestations of this kind of triggering of the inflammatory response. And it's very important, and as everyone on this call recognizes, not everyone gets the same symptoms, and not all of the people who get symptoms are the same. And it can vary all the way from people who are completely asymptomatic carriers to people who die. That's because the human body, all of us have different genetic changes, differences, polymorphisms are what they're called, and we respond differently. So some of us don't generate a whole lot of inflammation. Some of us generate more. And so that's why there's such a variability. Okay, so based on kind of the disease, how do we treat it? And the treatment is really mainly public health right now. I would say that we do have good treatments if you have to be admitted to the hospital, but wearing a mask is probably better than everything else combined. It's certainly a whole lot cheaper. Some of the more recent entries into the treatment sphere have been blocking antibodies. So this is just showing you coronavirus with its spike protein. It's binding to receptors on the surface of cells, and that's how it gets in. If we make antibodies, so that's these guys with the orange tag on the end, if we make antibodies that can bind to that spike protein, we can block that entry. And so there are a number of monoclonal antibodies, so cloned antibodies, and this is one of the names, bamlanivimab, at any rate, that we can use as blockers. And we can also use people who have had COVID, who have gone through the disease, have cleared it. They have circulating antibodies in their bloodstream. And so we can take their blood, purify the antibodies, and use that. So that's another mechanism, and this is something that has received approval by the FDA for use in people who are at high risk once they develop the disease. Remdesivir, everyone's heard about remdesivir. Remdesivir actually takes advantage of the fact that the virus comes in, here it is coming in, and it's got viral RNA, and it needs to make more of that, and so therefore it has an RNA-dependent polymerase. There's an enzyme that makes more RNA from the RNA. You and I don't have that enzyme. The virus needs to make that enzyme, and we can specifically block it. So remdesivir is one of the things that blocks that production of more viral RNA. So that's another effective way, or somewhat effective way, to treat it. And then because inflammation is the major kind of mortality driver, we can block the inflammation, and that's where steroids come in. So we give people glucocorticoids, which are significant, very potent inhibitors of inflammation. We can also treat the symptoms. So we can give oxygen therapy. We can support blood pressure when people have low blood pressure. And importantly, because there is a risk for secondary infection from bacteria, we can give antibiotics. So those are the other therapy modalities. Importantly, studies, controlled studies that demonstrated hydroxychloroquine are not effective, and certainly bleach, other than sterilizing surfaces, is not the way to go. Okay, diagnostics. This is probably the most scientific thing. I'm sorry, I apologize, don't panic. But it's important to understand how, when we're exposed to SARS-CoV-2, when we start or can detect either the nuclear material, the nucleic acids from the virus, or when we can start detecting antibodies from the virus. So the most important thing is when you're exposed to SARS-CoV-2, there is a window of roughly 2 weeks, hence that 14 days quarantining, of 10 to 14 days, where there's very low level. The virus is there, it's replicating, but it's below the level of our detection. And this blue line is indicative of the increasing probability of detection. This is by using PCR. So PCR is polymerase chain reaction. It's a nuclear test, and it is probably our most sensitive test, as I'll talk a bit about. but it takes a while to get enough virus so that we can detect it. So you can have virus kind of in your body for a week, and you may not have enough nuclear material, even on a nasopharyngeal swab, to detect it. The other thing that, oh, so also just in passing, this yellow line represents stool PCR. So if you've been kind of, you know, you don't really like the idea of someone putting a swab way up into your nose, consider the other way that we can detect this. And so I go with the nose. The other thing that I want to mention is that after, in most of us, after a couple weeks of exposure to the virus, we start making antibodies. And that's what these dotted lines represent. There are two different forms of antibodies. One is very long-lived. And so there are antibodies that indicate that you are now immune. And it takes a while for those to come up. Okay, so the PCR test is probably our most sensitive and specific, and it comes up relatively quickly. But there's another assay where we look for not the viral genetic material, but viral proteins. And this pink box represents the fact that we can detect viral proteins. They come up at a level later where we can detect them, and they're not quite as sensitive. So we'll talk a little bit about that. All right, so much for the scientific stuff. So the nasal swab for the...
Excuse me, Rick, we have
Sure.
a question. Where did the virus originate?
So I'll come to that. The virus actually did originate probably in the bat caves near Wuhan. Yep. So nasal swab for the PCR, so you can, and most people are aware of that. It is a molecular assay. It's detecting the viral nuclear material, nucleic acid. It can be done reasonably quickly, 3 hours, but the way that we do this in the hospitals or at any of the other testing institutions is that they batch it. And so that's why the turnaround may be as long as 48 hours or even 72 hours. The assay, that test costs between $50 and $100, and it is the most sensitive. So that's kind of the gold standard. It's very near 100%. Remember I said, though, that we could do nasal swab for viral proteins. And this assay is done on this. So you take, again, a swab up the nose, you smear it on there, and you do an assay that's just like the over-the-counter pregnancy test. You're looking for the presence of virus proteins. It can be done in minutes. And so, and it's also extremely cheap at $5 or so. But it's not as sensitive, and there's about up to 20% false negatives. So this may be used, though, for going forward, because it can be a very rapid assay for someone who does carry a lot of virus. And it's been proposed that this be the kind of the assay going forward, because we can do 10 to 20 of these for the same amount of money and get a result much quicker. So at point of care in your doctor's office or at a baseball game or at a concert, this may be something that is eventually adopted. And then we can look at the blood test for antibodies against the virus. Again, it's an assay very much like the over-the-counter pregnancy test. We can do it in minutes, costs about $5. And this may be something that we eventually use to demonstrate that you are immune, that you have antibodies to the virus. Not that you have the virus, but antibodies to the virus. Okay, the vaccine. And top of everyone's mind now is what's happening with the vaccine. So the idea is the same strategy that we talked about with those neutralizing antibodies. Again, here we have our virus binding to its receptor through that spike protein. This is just an artist's rendition of what the spike protein looks like. But if we make antibodies to that, then we can prevent them from getting in through their receptor. And that's what these kind of yellow things are. They're binding to all the spike proteins and preventing that. And that's what the vaccination is all about. We're trying to generate antibodies to block the spike proteins so that the virus can't get in. Importantly, the virus can't mutate that part of the spike, because if it mutates that part of the spike, then it can't get into our cells. So it's kind of a stalemate. It's a Mexican standoff. So people who are worried about the vaccine not becoming effective, it seems very unlikely at this point that that's going to happen. How do we generate these antibodies? So there are traditional approaches. Those of us of a certain vintage, and actually kids now too, also get the Salk polio vaccine. This is an inactivated virus. So we take the whole virus and we dunk it in some sort of preservative that keeps it from being able to replicate, but we can then administer that. And that's actually one that's in phase 2 trials at Picovac. We can do a live attenuated virus. This is what we typically use for mumps, measles, mumps, and rubella, or the Savin polio vaccine, where we mutate or we modify the virus. It's alive, but it's not able to cause infection. These are not really yet out of phase 1 trials, so we're not going to talk too much about that. We can also take a page from the playbook for the human papillomavirus. This is one that we're vaccinating kids for now because it prevents against certain venereal diseases. And it's a virus-like particle. So it looks like a virus, except that it's just the kind of the membrane and a whole bunch of the spike proteins inserted into it. So it's not exactly the virus. We can make purified spike protein. And we use the same strategy for influenza and the hepatitis B vaccines, where we just have purified spike protein, and that's the Novavax vaccine that you may see. What is currently been approved by the FDA for all of us to take is taking the genetic code, just the RNA, the ribonucleic acids for the spike protein. We inject that, and we have our own bodies make the protein. So it's not an intact virus. It's not even part of the virus. It's just the genetic code for just the spike protein. And that's what Moderna and Pfizer have been approved. And there are small variations in the way that that's assembled and put together. But basically, that's the approach. And this may actually be a good thing that they figured out how to do this, because going forward for any new virus that appears on the scene, we'll be able to identify how it gets into cells and very rapidly be able to manufacture the RNA that we can make the protein and block it. So anyway, Moderna. And Moderna, just to point out, the RNA comes from the RNA. So that's why they're called Moderna. The other one, the AstraZeneca and Johnson & Johnson, they are packaging up the genetic code for the spike protein. Instead of just giving the naked RNA, they're actually putting it in a different non-pathologic virus, so-called an adeno-associated virus, and that's how they're administering it. And these are very, very near approval as well. Okay, so people are very concerned. They've heard about this brand new strain. Well, this new strain is simply the spike protein has become better at binding. And that's why it is potentially more infectious. Because the vaccines are directed against that, and the virus can't mutate that without losing its ability to enter cells, we're actually probably okay with all of that. So it's not a problem yet. So do not worry that the vaccines that we're getting are not going to be effective. What about this herd immunity stuff? Well, so herd immunity basically means that we have enough of people with the immunity, either natural through having gotten the disease and then recovered, or through the vaccine, that there aren't enough hosts who can be infected, new hosts. So we're breaking the transmission link. And this has been estimated in various mathematical modeling at about 70% of the population. We're not there. We're currently somewhere between 5 and 10%, depending on who you believe. So once I get vaccinated, do I still need to wear the mask? And the answer is yes, for a while. The point is that when we demonstrated that the vaccine was 95% effective, the way that they demonstrated that was that they gave control or vaccine to various groups of people. They asked them to report when they had symptoms, and then they tested whether they were infected or not once they had symptoms. So all we know for a fact is that the vaccine very effectively prevents symptoms. People don't get sick. But we don't know yet, and it's under investigation, whether you can still transmit the virus even though you're not sick. So that's why for a while we will all have to wear masks. And that's this last point. Okay, so what's next? And so what's next is, when will we be back to normal? And I wish that I had a crystal ball. It's a question that we ask all the time at the medical school. Currently, we're teaching medical students virtually. and we all want to know when we're back together so that we can teach them in person. My best guess is the summer, and by summer I'm giving myself a lot of leeway, somewhere between June and August, and I think that we will be at herd immunity status. We will have had enough of a rollout and enough people will have been naturally infected and recovered that we will be at that 70%. Even then, yes.
I had another question.
Sure.
Do you have any concerns of long-term side effects with the vaccine? For example, cancer, reproduction?
No, no. So and in fact, traditional vaccines are basically give a protein that we want to make antibodies against, or give an inactivated virus that we want to make antibodies against. What we're doing with this RNA vaccine is no different than that, other than we're now instructing the body how to make the protein, but that new RNA doesn't become part of our cells permanently, and there is absolutely no risk of cancer or reproductive effects. So, can this happen again? And the answer is
Rick?
yes. Yes.
Another question.
Sure.
Are there any advantages to the type of vaccine Johnson & Johnson is developing over Moderna or Pfizer?
Yeah, well, so it depends on your point of view. And so the Moderna and Pfizer vaccines are very effective after one dose, but they get to their maximum efficacy after 2 doses. The Johnson & Johnson vaccine appears to be effective after 1 dose, or as effective after 1 versus 2. So there's that. The Johnson & Johnson and AstraZeneca vaccines also are really stable at room temperature. So as everyone's aware, as we're rolling out the Moderna and Pfizer, those have to be kept at very cold temperatures. The RNA is unstable. It falls apart very quickly. So if we don't keep them super cold, then the vaccine is kind of useless. So that makes it really difficult for portions of the country or the globe where they don't have refrigeration facilities. So I think that you won't see a major rollout of Moderna or Pfizer in third world developing countries just because they don't have the refrigeration capacity. So those are the advantages. And the cost is slightly different, but none of us are bearing the cost of the cost of the vaccine. So I think that's not a question. Hopefully that answers it.
Rick, in regards to the effective rate of the vaccine, what is generally attributed to the 5 to 6% that aren't effective?
Yeah, so that's a really good question. And I think that the feeling is, so for any vaccine that any of us have taken, there is somewhere between a 5 and 25%, sometimes more, for example, the influenza vaccine, where there is non-efficacy. And that may be because the person who is immunized, who's given the vaccine, their immune system has a blind spot for that particular antigen, for that particular protein, for that particular virus, and you never develop an immune response. So for example, hepatitis B, just hepatitis B, and forget about the vaccine for a minute. If I take 100 people and give them all hepatitis B, I would never do this, but if we did, 10% of them would never respond. They don't have the immune repertoire capable of actually seeing or responding to the virus. And so those are chronic carriers. There's probably in the population of the world 5% of people who just never make antibodies because their immune system doesn't have the appropriate repertoire to recognize the SARS-CoV-2. And so that's probably the major explanation for why there's this apparent failure rate of 5 to 6%.
Rick, can I continue? We have a few more questions.
Sure, absolutely.
Is the vaccine experimental? Do the companies who produce have a liability if a person is injured in some form or dies?
So I think as part of and I don't know all of the legal ramifications, maybe someone on this call will, but in developing the vaccines, there some as part of the Project Warp Speed, some of the legal responsibilities, culpability, that was taken away if there was demonstrated efficacy and safety by the trials. So that there is an anticipated rate of side effects. In the trials, the panels that judged the safety and efficacy found that the benefits far outweighed the potential risks. And the manufacturers of the vaccines, whether it's traditional or the novel approaches, have largely been, I think, absolved of any potential legal ramifications.
Rick, can you get the vaccine if you have an allergy to penicillin?
Yes, absolutely. The allergy to penicillin is very different. Now, there are components of the vaccine that kind of the preservatives, and not preservatives, but the liquid that it's in that keeps the RNA as intact as possible. So there have been clearly some allergic responses. They're extremely rare, and in almost every case that I'm aware of, it was an unpredictable thing. But when people go for their vaccinations, they will be observed for 15 to 30 minutes. Afterwards, they won't be allowed to just get a shot in the arm and then leave. We're going to make sure that they don't have any kind of allergic response.
Can you get a Moderna vaccine and then get a more stable one later? Basically, can the vaccines be mixed?
Oh, sure. I mean, so they're all directed, all of the vaccines are directed against the spike protein. So it is possible that you might initially get the Moderna vaccine or the Pfizer vaccine, and then if we decide that we need to have boosters in the same way that we have measles, mumps, and rubella boosters every year, or as we have tetanus boosters whenever, you may get boosters at a later point, and you won't have to use Pfizer or Moderna. You can use the Johnson & Johnson or AstraZeneca.
A couple more, Rick. Can you get the vaccine if you are pregnant, and is it safe to pass through with breastfeeding?
Yes. So my understanding is yes, that it is safe for pregnancy, and the antibodies once generated, not the RNA, but the antibodies once generated will pass through in breastfeeding.
Great. And one more. Can you discuss risks associated with comorbidities?
Yeah, so the major comorbidities that have been associated with adverse outcomes, and it sounds so sterile when I say it that way, adverse outcomes meaning death. The major ones are age. So the vast majority of people who are dying are 80 and older. And there is a much higher risk in that population, probably because the stress, once the immune system gets activated, the stress of that hyperactive immune response basically aggravates pre-existing lung disease, coronary disease, and other things. So if you have pre-existing coronary disease, if you have pre-existing lung disease, that puts you at increased risk as well. Obesity is another one for unclear reasons, although it may be related to an altered immune response in the setting of diabetes or pre-diabetes. So the risk factors are really, do you have prior things that if we make you really, really, really sick, are you going to be tipped over? And so it's things that you would expect. Known coronary disease in the heart, known bad lung disease, that kind of stuff.
Rick, there has been information indicating that individuals with vitamin D low levels are more adversely affected by the virus. Is that true? And then the second part of that question is, Are there any supplements shown to prevent or help treat the virus, like zinc, vitamin C, and vitamin D?
So when people, okay, so vitamin D in general is getting, it's suddenly become a very sexy vitamin, at least for the immunologists of the world. There seems to be improved overall immunity if you have normal levels of vitamin D. So the interpretation has been, gee, if you have low levels of vitamin D, then you might be more susceptible. As far as I know, there haven't yet been sufficient studies that would convince me about that. Having said that, having adequate vitamin D for calcium metabolism and all the usual things, especially in the middle of the winter months when we don't see much sunshine, taking a vitamin D supplement, not a bad thing. I certainly wouldn't overdo it. You can get vitamin D toxicities if you decide that you're going to take 20 of those suckers every day. Other supplements, so vitamin C, zinc, vitamin E, pick your favorite, have not been shown to have any efficacy to date.
Okay.
Okay. So,
There's still more.
okay. Wow. Okay. Good.
Yep. Do you have any insight? Do you have any insight to what's happening in Massachusetts compared to other states with vaccine supply and the number of immunizations?
I don't. I know. I know what's happening in the medical community, and pretty much everyone, all the way down to medical students. If you have any patient-facing activities, we've been at least gotten a first round of vaccination. I do not know what's going on more broadly in Massachusetts. I know that there's been a slow rollout, and I don't entirely understand why versus other areas of the country. So I, talk with colleagues around the country, and 60 and 70 and 80-year-olds in various other states in the United States have already been vaccinated, and yet we are woefully behind here in the Commonwealth. But I don't understand or know why.
Rick, this is a follow-up on the non-effective percentage that you had discussed earlier. If 2 weeks after a vaccine you were to test for antibodies, is it safe to assume that the vaccine was effective for you?
So if you have antibodies demonstrated at that point, yes, it has been effective for you. And that's why I said that it may ultimately be that we do that rapid point of care kind of over-the-counter pregnancy-like test looking for antibodies. That would demonstrate that you've been vaccinated or that you have immunity to the virus. So yeah, I think that's safe to say that you've had a response. So far, the country, the Commonwealth, even in the hospitals, we are not routinely testing for whether or not you've raised an antibody.
Are you at a higher risk of reaction to the vaccine if you have a severe allergy to ACE inhibitor drugs?
Interesting question, and the answer is probably not. That's a really interesting question, and I don't know that there's any data on that. The ACE inhibitor, so there are a number of medications that actually act to block that ACE receptor. Losartan is one, and I do not know if there is enough data. The incidence of people who have allergies to those ACE blockers is really, really low because the spike protein binds to it rather than looks like the ACE. I don't think that there's any increased risk, but I don't know that for a fact.
Rick, do you have any insight if financial service employees will be eligible to get the vaccine early?
I don't think so. I don't think so. But it depends on what Governor Baker decides for the Commonwealth. And so people who are frontline workers, so hospital workers clearly, people who teach, and other kind of frontline people are are at the front of the line. If Governor Baker, in his infinite gubernatorial wisdom, decides that people in the financial sector are frontline critical workers, then they will be moved to the front of the line. But that's kind of way above my pay grade, so I don't know.
And Rick, it looks like this is the last question. Most of us do not have N95 masks and are using store-bought medical procedural masks or cloth. Which type of mask would be more effective, assuming N95 masks are not available to the individual?
Yeah, so this has been debated kind of all over the globe. I think the main point is a mask rather than what kind of mask. So their particles will get through. I mean, when I showed that image of the sneeze, there are clearly, even if I put a mask on, there are still particles that get through. So it is short of actually putting on an iron face shield, you're not ever going to be zero in terms of the amount of virus that you can potentially release. I think the main point is whatever is available. And in my daily activities, I wear both cloth and the hospital masks. I don't, because of a beard, the N95s don't fit and are not approved for my use. But I think the main point is to use a mask rather than to worry too much about which ones are most effective.
Okay,
So let me just finish up. This is my last slide, and then I'll address any additional questions.
Sure.
So in terms of what's next, can this happen again? And the answer is unequivocally yes. It's not a matter of if it will happen again, but it's a matter of when it will happen. And the main reason, it's a really small world, getting smaller, and we are encroaching more and more on animal populations. And that's, remember, coronavirus can infect basically the entire animal kingdom, and it can go about its little business out there in bat populations or whatever. And then as we encroach on those populations, the virus periodically learns the trick necessary to jump into a human population. So it's going to happen. And this is just an image from the Spanish flu. In fact, the Spanish flu happened in 1918 because there was a leap from probably a bird flu that was being carried by birds into the human population. And it was a novel virus, much like the SARS-CoV-2 is a novel one that we've never seen before, and it caused this. But even in more recent memory, HIV, brand new virus, never really heard about prior to about 1976. MERS, I already talked about the Middle Eastern Respiratory Syndrome virus, and the first round of SARS, these were both coronaviruses. Everyone knows about Ebola, everyone knows about Zika, there are others. So there are always going to be new viruses that are out in the animal community that periodically make the leap into the human population. And this is just the wet market, so you can see the bats. Almost certainly there was a coronavirus that arose in a bat that was probably not pathologic in the bat, but did get into the human population in that particular setting. And this is a pangolin, which is also been found to be a carrier. It's kind of a cross between an anteater and an aardvark or armadillo. And so the pangolins were also probably carriers, and they were also in the wet market. So the upside, the silver lining is that in 2020, we learned how to better detect that there is a pandemic, and we have learned kind of the best practices about how to mobilize. And also now we have a vaccination strategy. That is to say, let's just make the RNA for an important protein that the virus uses to get into us, and we'll be ready faster the next time around. So hopefully we'll do better. Okay, and so thank you, and any additional questions, happy to answer. I realize that there is also a board meeting that we need to get to.
There are no additional questions at this time, Rick. I think you answered them all.
Okay.
Oh, wait, no, Paul, hang on, Paul. Let me just unmute you. Go ahead.
Question came across my screen. Someone asked about traveling on a plane. Came across on my screen.
Yeah, so the air in an airplane is recycled. It has to be, but it's scrubbed pretty effectively. If any of you have traveled recently, I haven't. I've been shut down I'm not allowed actually to have any kind of travel outside the Commonwealth. This is mandated by my hospital. Otherwise, I will have to quarantine for 2 weeks. But if you have traveled recently, you have almost certainly noted that there is an increased heightened kind of social distancing, mask wearing. I think that traveling in an airplane at the densities that are currently being transported around is no different than going to your grocery store in terms of risk.
Right. Rick, thank you so much. It was very timely and very informative, and I'm sure everyone really enjoyed your presentation. Thank you, thank you, thank you.